Hello everyone, and welcome to Oral Pathology Tuesdays on Oral Pathology 360. I'm Dr. Mandana Donahue, and I'm delighted you are here for today's session. Today, we will be exploring an important and practical topic: conservative management of jaw cysts and tumors. For oral surgeons, this is a valuable opportunity to refine and update surgical approaches. And well, for the rest of us, it's a chance to deepen our understanding of treatment choices that shape patient outcomes. Before we start, a few housekeeping announcements. If you're watching from anywhere else but YouTube, and you would like to interact with us, please head over to YouTube. And of course, you can watch it from wherever you are, any of the apps or even our website. But to interact with us and ask questions, you need to be on YouTube itself. Then, for a clearer picture, ensure that you tap the settings gear and switch the quality to 720p or higher. We also have certificates for our channel members, and to get that, you need to join our YouTube community, which you can do from hitting the join button below the video. And then you need to attend the live stream, interact with us in the chat so we know you're there, and fill up the form that is there, that is shared on in the posts. Now, I know last time there was some glitch, and I think nobody managed to fill up the form. I realized it just now when I was resharing it. So I will set it up and inform you all through the post to fill up for last times too. Now, coming to, of course, another thing we got to say before we move on, we have a very heartfelt thank you to our new members. Now, moving on, it is my pleasure to welcome our speaker for today, Dr. Pramod Krishna B, Professor and Head of Oral and Maxillofacial Surgery at BGS Global Institute of Medical and Dental Sciences, Bengaluru. That's in India. He'll be sharing his own case experiences and long term follow up outcomes on conservative approaches to managing jaw cysts and tumors. And it is not even the first time he was with us, he has been with us. At the IODCPC conference, or rather the pre conference course, he has presented the lecture, and it was very well received and very interesting, which is why he is now sharing a lecture with us today. So, thank you and welcome, Dr. Pramod.
Thank you very much, Dr. Mandana. It is a pleasure to be here again. My association with Dr. Mandana dates back to 2008 when I was working in the remote part of India, and she had helped me with all my histopathological diagnosis. I was in Himachal Pradesh, and I used to courier all my specimens to her, and it was indeed a privilege to be here again with you. Thank you, Dr. Mandana.
Thank you so much, and thank you for remembering that. It's such a long time back.
Yeah.
Yes, it's nice. Now I do remember that. Yes, we used to get your specimens. Okay,
Yes.
so as usual, we have the lecture recording. We will play that, and we will come back for the discussion. Don't go anywhere. Listen and put in your questions in the chat.
Good evening, everyone. I am Dr. Pramod Krishna. At the outset, I would like to thank Dr. Mandana for inviting me to share my experience. I am Professor and Head, Department of Oral and Maxillofacial Surgery, BGS Global Institute of Medical and Dental Sciences, Bengaluru. My areas of expertise are maxillofacial trauma, temporomandibular joint surgeries, maxillofacial pathology, and minor oral surgery. Today, I'm here to share my perspective on conservative management of jaw cysts and tumors. What is a blissful state? It is a state of being in which one would understand completely what is being done. For a surgeon to be in a blissful state is knowing what he is doing and the outcome of his procedure. So, this quality is attained by not an accident, but it is always the result of an intelligent effort. It's the will to produce superior things. As well as defines neoplasm as an abnormal mass of tissue, growth of which exceeds and is uncoordinated with the surrounding mass of tissue and remains in the same excessive manner even after the cessation of the stimulus. This neoplasm is polarized into being malignant and benign, as we all know. But there is something in between benign and malignant. Though histologically these lesions are benign, it shows a very aggressive behavior, aggressive biological behavior, and these can be termed as aggressive benign tumors or aggressive benign neoplasms. And when it occurs in head and neck region originating from odontogenic epithelium, they are called aggressive benign odontogenic neoplasm. And the challenge in treating these tumors are because of its aggressive behavior. It has considerable potential to grow to enormous size. It invades into adjacent tissues and spreads beyond clinical and radiological margins. And because of all these features, there is high rate of recurrence in these kind of neoplasms. Aggressive benign odontogenic neoplasms include but are not limited to multicystic ameloblastomas, parakeratinized odontogenic keratocysts, and even many other odontogenic neoplasms which has a biological behavior by which it can be categorized as aggressive. So the general consensus in management of such kind of neoplasms are complete eradication of the tumor either by marginal resection, segmental resection with disarticulation. But what's the plan to manage the post-operative deformity? Post-operative deformity is sometimes very debilitating, wherein the patient will have a very morbid post-operative conditions. So should we reserve such treatment only for malignant diseases or malignant cases? I would say yes. When you are able to treat a disease in a conservative way, you should always give it the first priority. So what are the conservative management options? This includes enucleation, marsupialization, and curettages, though curettages are never recommended as sole treatment of choice in management of any kind of uh, cysts or tumors. So one surgeon's aggressiveness becomes another surgeon's conservative. So in general, conservative management of any benign cyst and tumors, if it is a smaller lesion, then it has to be only enucleation. If it is a bigger lesion, then it is treated with enucleation. Enucleation by itself has a very high recurrence rate. In order to reduce this risk, adjunctive procedures such as peripheral ostectomy, Carnoy solution application, and cryotherapy have been reported. Carnoy solution can penetrate and fix to the depth of up to 1.54 millimeter into the bone after 5 minutes of exposure. On the other hand, the surgical space that is created by removal of these lesions requires packing with aseptic dressing material to achieve uneventful wound healing because primary closure may lead to infection because of dead space. Ideal dressing material used in the mouth should be able to reduce postoperative pain and also should promote healing and prevent infection. So enucleation followed by peripheral ostectomy by removing all the bones that is there around the enucleated cavity along with chemical cauterization with modified Carnoy solution because one component of Carnoy solution which is chloroform is banned by FDA, thereby we are nowadays using modified Carnoy solution with open packing of bismuth iodoform paraffin paste. So let's briefly know about the history of Carnoy solution, its application in medical field. Carnoy solution was first utilized as a histological fixative for the study of nematodes. In 1887, due to its ability to preserve the integrity of the cells, including the nuclei. In 1931, Cutler and Zollinger were the first to use it as a sclerosing agent for the treatment of various cysts and fistulas in the brain due to its unique property of moderate penetration, rapid local fixation, and excellent hemostatic action. Woodsmith, Stollinger, and Van Helst were the first to use Carnoy solution as a chemical cauterizing agent in the treatment of odontogenic keratocysts in the maxillofacial region. Woodsmith protocol for the use of Carnoy solution was application of Carnoy solution for a duration of 5 minutes in the defect region, which results in necrosis of 1.5 millimeter depth. In 2000, the FDA banned the use of chloroform as it has been found to be carcinogenic. This led numerous surgeons to adopt a modified Carnoy solution, that is, which is devoid of chloroform. There are only few studies in the literature which have reported the effect of modified Carnoy solution on the depth of penetration to cause necrosis of the bone. So let's compare the composition of Carnoy's and modified Carnoy solution. Carnoy's solution contains the following chemicals: ethanol, chloroform, which is in 1:2 ratio, that is one part of chloroform and two parts of ethanol, glacial acetic acid, and ferric chloride. In modified Carnoy solution, except for chloroform, all the other ingredients are kept, but only the concentration of ferric chloride is increased. That is, you're using 6 ml of ethanol and using 1 gram of ferric chloride and 1 ml of glacial acetic acid. So there was a study which was conducted in comparing Carnoy solution and modified Carnoy solution to know the depth of penetration of the solution to cause the necrosis within the bone. So it was concluded that the depth of modified Carnoy solution is equivalent to Carnoy solution when it is applied for 10 minutes. But when it is applied for 5 minutes and 8 minutes, the depth of penetration was more in Carnoy solution compared to modified Carnoy solution. So a simple take-home message is, if we are using modified Carnoy solution, then we need to keep it for a little longer duration, or to be more precise, twice the time where what we used to keep for Carnoy solution. Then coming on to the packing of the defect, which is caused by uh, enucleating a large benign cyst or tumor. So the open packing is the most preferred method of allowing the granulation tissue and bone to fill in by secondary intention. So the most common formulation used for packing the wound is bismuth iodoform paraffin paste. This formulation includes bismuth subnitrate, which acts as astringent to reduce tissue contraction and contributes to antibacterial properties, while paraffin serves as a lubricant to minimize tissue trauma during packing. In one retrospective study conducted by Zhao, he recommended use of local anesthetic agent during first two pack changes after surgical enucleation. This combination facilitates seamless application and removal of BIPP. The antiseptic properties of BIPP are further enhanced by nitric acid, which is speculated to potentiate the release of iodine. Iodoform has also been shown to be effective in debridement by facilitating collagen fibrolysis and its attachment to necrotic tissue. This action mimics that of collagenases, essential enzymes for removing unprocessed collagen fibers that would otherwise anchor necrotic tissue to the wound surface. Additionally, iodoform can stimulate granulation tissue formation, thus promoting wound healing. Beside its antiseptic properties, iodoform imparts marked anesthetic effects, and the impregnated gauze impermeability to blood and body fluids makes it resistant to bacterial growth. This packing of iodoform gauze usually on an average goes up to 10 months. According to the same study which I quoted previously, ZOS study, the average is between 7 to 15 months. So on an average, 10 months of packing is required. So the most important factor in success of conservative management of aggressive benign odontogenic neoplasm is to have a very long term follow-up and a very good patient compliance. As now I take through the series of patients which has been treated by me of such lesions, uh, I would say that in case one has to err, better to err on the safe side, that is conservative side. If recurrence occurs, it can still be treated. There has been reported cases where the recurrent lesion has had a different histological presentation. That is, the first time when it was operated, it was odontogenic keratocyst, but the recurrence when it was treated had turned into an ameloblastoma. But still, the ameloblastoma is also a benign lesion, so it can still be treated conservatively without resorting to uh, radical surgical procedures. So here is my first case, a 60-year-old lady who presented to our hospital with a 5-month history of swelling and occasional pain in the lower right posterior teeth region that gradually worsened. She did not give any history of dental infection or trauma. Her medical history was not relevant. On extraoral examination, facial asymmetry was evident with diffuse swelling approximately measuring 4 centimeters. On intraoral examination, it was revealed that there was considerable buccal and lingual cortical expansion with vestibular obliteration from lower second molar to second molar. As a screening panoramic radiograph, it was revealed that there was a large multilocular radiolucency involving whole of right side of ramus of mandible up to sigmoid notch and anteriorly up to first premolar. The radiolucency had thinned down to the lower border of the mandible, making the lower border very thin. After initial clinical and radiological examination, the patient was subjected to CT scan. In the CT scan, it was found that there was a well-defined expansile cystic lesion, which was approximately around 4.5 into 4.3 into 3.3 centimeter, and the axial section showed some areas of buccal cortical perforations and lingual cortical perforations. and there was also the lower border perforations, but the tumor had not uh, come out of I had not invaded the soft tissues. So an incisional biopsy was done. Before doing the incisional biopsy, a wide bore aspiration was done. On wide bore aspiration, a cystic fluid, brown color cystic fluid was seen. Fine needle aspiration cytology report was also suggestive of some kind of benign cystic lesion, and the possibility was more towards odontogenic keratocyst. Further biopsy or the histopathological diagnosis of incisional biopsy revealed that the lesion was an uh, parakeratinized odontogenic keratocyst. The patient was taken under general anesthesia, and a thorough enucleation of the cyst was done, followed by peripheral ostectomy. Uh, as we can see here, the lesion was very fragile. So that is the reason I was not able to remove the lesion in toto. So so such kind of lesion are more prone for recurrence. So along with the cystic lesion, the tooth was also removed, and all the bone of the cavity was trimmed by peripheral ostectomy, followed by application of modified Carnoy's solution for around 10 minutes. And the suturing was done in the anterior aspect of the incision, and posterior aspect of the incision was packed with uh, BIPP pack, bismuth iodophin paraffin pack. Then this lady was followed up every week, and the pack was changed. Bismuth iodophone paraffin pack was changed. Gradually the length of the pack started becoming less, and after almost 7 months, the presentation was something like this, wherein we were not able to pack the cavity because it was not getting retained. At this point, a simple plate was fabricated to cover the defect, and after the patient wore it for another 2 months, the defect was like this. Thereby, the complete healing was noted in around 9 months. So this was the clinical picture. In this slide, in this slide, we are seeing the radiological preoperative picture of radiolucency seen in the right ramus of the mandible. And ideally, I would have preferred to radiograph the patient after 3 months. But in this case, the patient, uh, there was a small sequestrum which was found in this region. So I just wanted to see what it was. So after 2 months, this radiograph was made, and here there was a small piece of sequestrum which was seen there, which was removed. And after 7 months, this was the radiological picture of the patient. There was a good amount of bone fill which was seen here, and this is the 9-month post-operative picture, wherein there is a very good amount of bone that is formed in whole of the body ramus of the mandible. So we could come from here to here in a matter of 9 months. But all benign odontogenic tumors has to be followed up for a very long time, because there has been reported cases of recurrence even after 4 years. So the crux is to keep the patient under a very long-term follow-up. This is the second case wherein there was a huge multilocular radiolucency measuring around 7 into 3 into 3 centimeter, involving the right ramus of the mandible. Here also the lower border was very much thinned out. There was buccal, and there was some areas of buccal perforations, and there was areas of lingual perforations too, along with buccolingual expansion. This patient also presented with pain in the right lower back tooth region, which was noticed 3 to 4 months before. And this patient was a very young lady who was about to get married. And looking at the age of the patient, we decided on just going for the conservative management. The protocol was all the same: to perform a cyst enucleation followed by peripheral ostectomy and chemical cauterization with modified Carnoy's solution. And the patient was also regularly packed with BIPP. In this case, the packing was done once in 15 days. And this was the amount of bone fill which I got after 3 months. And this is the amount of the bone fill which we are seeing after 1 year. The patient is still under follow-up, almost 4 years. I'm sorry that I don't have recent OPG right now. And there is no signs of recurrence. This is a third case. In this case, again, patient complained with swelling it was a 14-year-old child. The swelling was noted in the lower anterior region, and also on the posterior region on the left side. Uh, there was good amount of buccolingual bony expansion which was noted. Initial radiographs were occlusal films and OPG. And occlusal films, there was the buccal and lingual expansion which was noted. On CT, the size of the lesion was around 7 into 3 into 3 millimeters, centimeters. And this case was also, the protocol followed was also the same. That is, surgical after incisional biopsy, after aspiration, after incisional biopsy, surgical enucleation under general anesthesia. You can note the lining in this case. It is relatively very much thick compared to the lining that we saw in our first case. In this case also, the protocol was same: to do the enucleation followed by peripheral ostectomy and chemical cauterization, and the iodoform gauze was placed. But in this case, we also used obturator to uh, close the defect, and on periodically the obturator was trimmed. So this was the lesion. So I specifically put this picture to show you that, along with removing the a very well encapsulated cyst, all the remnants around whichever was seen in the walls of the cystic cavity was also thoroughly removed from the bony cavity. So this helps us in preventing, to a maximum extent, uh, recurrence. Along with that, the peripheral ostectomy and chemical cauterization was also done. So in this case, after packing for few weeks, uh, we gave the patient an obturator, and the obturator was sequentially trimmed till the defect was completely closed. So here is the preoperative radiograph showing a multilocular radiolucency, and then this was in 1 year follow-up. Good amount of bone fill is seen here. This is a 2 year follow-up, and this is the 8 year follow-up. So basically, if given a chance today, I wouldn't prefer doing this because I would still remove all the teeth, because any cystic lining which is there entrapped between the roots of the teeth cannot be thoroughly removed if we choose to retain the tooth. So today I would still remove the tooth along with the cyst. So this is the last case which I will be discussing. Um, it is a very well circumscribed homogeneous unilocular radiolucency around the coronal aspect of the impacted lower third molar. Uh, the only problem in this case was the lower border had very much thinned out. So because of thinning out of the lower border, there was a good chance of mandibular fracture. So in this case also we did a simple enucleation of the cyst along with the removal of the impacted tooth. Patient reported to me after 2 months telling that the previous day she bit on something hard, maybe a chapati or something, and then suddenly she developed a severe pain. So the very next day I radiographed the patient and I found that the patient had a crack. I would not call it a fracture. It was an incomplete fracture because there was no buccal. The buccal bone was removed to maximum extent. So probably the lingual plate had fractured, but it had not gone up to the lower border. So here comes the need to explain the patient when we are treating such cases that there is a possibility of fracturing the jaw. So they have to be prepared uh, for that complication, and then they have to uh, give consent for the same. So fortunately in this case the fracture was not extending to the lower border, so I just advised the patient to have the soft diet, and eventually this was a 7 month picture. The bone fill is still happening, and thereby over a period of time I ensure that there will be good amount of healing, and this dental rehabilitation can be done in these cases with uh, intraosseous implants. So coming on to the conclusion, uh, the main point of treating all such benign lesion in a conservative way is to preserve the structural and functional integrity for better post-operative quality of life for patients. Definitely, when you have a mutilated jaw following a malignant tumor, you have an option of microvascular reconstruction. But microvascular reconstruction for a benign tumor jaw resection, I feel, is over treatment. Definitely, when the tumor is spread beyond its anatomical boundaries, such that it has gone out onto the lingual soft tissues or on the buccal soft tissues. So in those cases where you are not able to, whole of the bone is not there and you're not able to achieve a soft tissue closure, in those cases you can still uh, expect to do resection followed by microvascular reconstruction, because nowadays reconstruction means the gold standard is always a microvascular reconstruction or a free flap. Uh, but when you do a good enucleation followed by peripheral ostectomy and chemical cauterization with modified Carnoy solution application, followed by allowing the cavity, big cavity to heal by secondary indentation by packing that wound by iodoform gauze, is an ideal recommended treatment as a conservative management for any kind of benign odontogenic neoplasm. But all these things can be done only when we can assure that the patient will be coming for a long-term clinical and radiographic follow-up. And this is very much essential because of the aggressive nature of these benign odontogenic neoplasms. There has been cases, reported cases, even in one of my case also. I'm sorry, I'm not able to showcase all those cases because I don't have enough of photographic evidence or photographs. So initially, I had treated the case with enucleation, since the histological diagnosis was uh, odontogenic keratosis. But when that lesion recurred after 3 years, we further went ahead and did an incisional biopsy, and the biopsy report turned out that it was a follicular ameloblastoma. But even in the second surgery also, I again did a enucleation, and patient is still kept under follow-up for almost 3 to 4 years, and there are no signs of recurrence. So I would like to conclude by telling that uh, ethical and good use of uh, techniques such as enucleation, peripheral ostectomy, use of chemical cauterization, and packing the cavities. And if it is any small lesion, you can directly go ahead and do a primary closure and just keep the patient under follow. So that will effectively treat any kind of uh, odontogenic neoplasm, aggressive odontogenic neoplasm. Uh, I once again thank for giving me this opportunity to share my humble experience with the people. Thank you very much.
Thank you so much. That was a very informative and interesting discussion, I must say. Uh, Especially, I think even more interesting from a pathologist point of view. But
Yes,
yes,
yes, that's true.
very nice. Thank
Because
you.
everything
Because we
depends
always
upon the
talk
biological
about,
behavior.
yes, no, and we always talk about, how the treatment is done and how extensive it has to be, but we don't really think, we just have a theoretical idea that this is the treatment. We don't
Right.
really go into the depth of it. Yeah. And another thing I noticed, which was interesting, is that the oral surgery view is very different from oral pathology. In pathology, we are always told to follow the worst diagnosis. If we have a doubt that something is, say, moderate or severe, if it is on the borderline, we are supposed to mostly go with severe rather than moderate,
Yeah,
because
that is.
you would expect it to be treated accordingly. But you are thinking of going a little less, I would say, stepping back rather than stepping forward.
Yeah, that stepping back is only in the cases where it is histopathologically proved to be benign. So in
But
that benign, there is aggressive benign and less aggressive benign and things like that. So, but when it is malignant, then there is no looking back at all. Then it has that whole
yes,
of the treatment protocol changes. So that's how it
that
is.
is true.
And nowadays you have a lot of like for example in case of odontogenic keratocyst also, the most of the spread of the lesion is in the mesio distal dimension or within the marrow spaces, and it is basically because of interleukin 1 or any kind of thing which are the mediators of inflammation. so which induces the osteoclastic activity. So with all of these things can be handled if we are able to thoroughly remove the lesion. So there is no compromise in not living the not removing the lesion. So lesion has to be completely eradicated, no doubt about it. But whether we have to go be very extensive and remove unaffected surrounding bone, so that is the point of whole debate in these kind of aggressive
And
benign
I'm very glad it works
odontoplasms.
because it is very sad to see patients with something like an ameloblastoma or an OKC losing half their jaw. It is really
Right, right,
heartbreaking to see those
right.
patients.
Right, but everything comes with a kind of a caution. You can say that the patient has to be followed up on
Yes.
long-term basis, because all these benign
Mm.
lesions do not recur similar to a malignant lesion. It recurs probably after 4 years, 5 years, 8 years, even up to
Mhm.
10 years also. So the following up the patient is very important, actually.
Very important. Yes, I noticed your follow-ups are nice and long. Yeah,
Yeah.
that's really good. Yes. Okay, while we wait for some more questions to come in, let me just share some information. One is that we have an entire odontogenic lesions playlist now. If you see on our playlists on the channel, you'll find odontogenic, and there are in that there is a combination. If you are looking for oral surgery, then look for oral surgery. We also have a playlist of oral surgery. On the immediate topic, we had a lecture by Dr. Sujata Mohanty, where she shared her experience of managing odontogenic keratosis for 25 years. It's also
Oh,
there on
that's
the
a good.
channel. And well, there are a whole lot of lectures, as you can see listed here. There are now 17 videos touching on the odontogenic range of diseases. I'll try and share the link here in the chat afterwards, but it is also there in the posts, and you should be able to find it quite easily. Then a couple more reminders, especially if the slide moves. Okay. So we are having a very different, I would say, a webinar. This one is for faculty development, and it is for faculty within all of the health sciences, where our learning is a little more intense, where the courses are a little more difficult and possibly more taxing to the students. So, this is for you to find, to recognize the early signs of depression and possibly suicidal ideation in students. We have had a few unfortunate incidents in the recent past that made us think that it is time we do this. So if you would want to register for this, I have put the link was I think in the top two parts of the chat, top two comments. So it is there. You can enroll. You can also please share it with anybody within the health sciences. Let it be medicine, dentistry, nursing, physiotherapy, homeopathy, Ayurvedic, absolutely anybody. Where there are students, where there are young students, and the courses are little taxing. I think it would be helpful. So please remember to share that and also to join up. Seats will be limited, so please hurry. Then the next thing is we had a master class on biopsy techniques while the live is finished, but we have kept it available as a recording for up till the 5th, and you can still watch it. You can still make use of it. It got very very good reviews. And the last is to just remind you, you can still add your name to the list of people who will get information about our International Oral Diseases Case Presentation Conference 26. The date is fixed, 8th to 10th of May. Everything will be there, the same. I hope will be better than last year. And well, everyone who joins our early list will get a special discount because we will introduce open registration to those on the list first with a very dedicated and separate discount. So get on that and add your name there. It will be helpful. Okay, now let's get on with our next screen and where we can bring questions. We already have one from Dr. Archana. Says, excellent one. Nice lecture. Please, can you elaborate on marsupialization? I can't even pronounce it properly. Okay.
Yeah. Yeah, marsupialization is a modality of treatment of cysts wherein the cystic lining is not wholly removed from the cystic cavity. Rather, the flap is raised, similar to how we do an enucleation, and a bony window is made, and the cystic lining is identified. After identifying the cystic lining, only the outer wall of the cystic lining is incised, and the cystic lining is sutured with the oral epithelium. So all around the cystic lining is sutured to the oral epithelium so that the whole of the content within the cyst is decompressed, and the patient is followed up. So this is something wherein the whole of the cystic lining is not removed. The cyst, once the bone fill starts happening, the cystic lining, if it becomes small and still you are able to differentiate between a cystic lining and the oral epithelium, it can be enucleated. Otherwise, you allow the cystic epithelium to become the oral epithelium. But coming on to the negative aspects of marsupialization, you are not getting the tissue for biopsy, so you don't know what is the biological behavior of the cyst. And second thing is the cystic I mean the marsupialized tissue, it can fill the bone definitely, but you are still leaving back the cystic epithelium. So it is like any time it can get converted into a full blown cyst or tumor or something like that. So this kind of treatment modality is usually advocated in cases where you have an erupting tooth, like as in case of first mandibular, first molar. It is coming into the oral cavity, but then you have the cyst around it, eruption cyst is there. So in those cases, yes, marsupialization is a treatment of choice. Other than marsupialization, you have something called decompression also, wherein you actually don't suture the cystic lining to the oral epithelium. You just open up the cystic cavity and then decompress it and allow the bone fill to happen. And then once it is small, you enucleate whole of the cyst. So marsupialization is a treatment of choice in a huge cyst or a big cyst, which might jeopardize the bone. I mean, which will trying to enucleate that large cyst will end up having pathological fractures. In those cases, you will plan for a marsupialization.
Yes. Very interesting. Actually, I was looking at your cases which you have shown. I think that was the ameloblastoma with typical multicystic, where we see
Yes.
radiographically that soap bubble appearance. So I was just
Yes.
wondering how you could manage to clear uh, all of the growth and the
Yeah.
unsupported bone, because there will be like spicules on the inside.
Yes, there would be some spicules from inside. Yes, it was a solid tumor, I mean, solid lesion, basically. But then, when you are able to get that margins, that is the margin between the normal, bone and the tumorous lesion, you just follow the plane. That's all. So once you follow the plane, and little patient with yourself, and then slowly go inside, and then ensure that you're not, because most dreaded complication in enucleating such kind of lesion is to have a pathological fracture. So I've been fortunate till now that didn't have to face that, but then there is always a possibility of having a pathological fracture. The problem in removing these kind of lesions is like when it has actually come out of the bone and it has invaded the soft tissues. So in those cases, we don't have an option other than doing a resection.
Okay. Oh, all right. That's interesting for me. Okay. So I would not have thought that the involvement of the soft tissue would make that much of a difference. This is
Yeah, yeah,
interesting.
because that is when we have a sure shot indication of a resection.
Okay. So that I guess because when it is bony and now it has extended into the soft tissue itself tells you it is much more spread and much more aggressive.
Right, right. It also depends on when the patient has presented to you. Like probably the lesion has been there from years together, but the patient has reported to you after a very long time.
Correct. Yeah. Sometimes I mean, I, in books and otherwise, we have seen lesions which are, especially ameloblastomas, that you can't imagine somebody actually tolerated that lesion for that long without, you
Right,
know, showing it to a doctor. It's shocking
right,
how
right,
big those lesions can be.
right.
But I guess it happens. It happens for all sorts
Yeah,
of things, including the fact
yeah,
that people are scared of doctors and scared of
yes,
going to doctors.
right.
Yes. So, any other questions, folks? I'm waiting to see if
Uh,
any of you have any questions. Interestingly, our regular the people who have signed in, where I can recognize, are the pathologists, except for Dr. Rahul. I don't know is a
yeah,
I mean, sorry,
he is a
pathologist and
postgraduate
oral
student.
medicine. Okay, fine.
Yeah.
So yes, so it is nice to have our regular people around. And everybody, if you like the lecture, please remember to hit the like button at this point. It's a good time to do it. And yes, what would you like to add?
Um, yeah, probably. Um, I think any cysts or tumors, like in Western world, you have the. I mean, you need to get yourself radiographed once in a year. I mean, OPG's orthophantomograph scanning once in a year is mandatory. So these tumors never present. I mean, when it presents to a doctor with pain and swelling, it is already in a very later stage, a very late stage. So regular, I mean, we should come up with a protocol wherein jaw should be radiographed at least once in a year or something like that. And if there is any suspicious lesion, then it has to be addressed immediately surgically.
True. I don't think we do that. We don't do that at
Pardon?
all. I mean,
Yeah, yeah, yeah.
we don't do it just diagnostically, in a
Right.
way of
Hmm.
just screening kind of a thing. Um,
Right. Right. So
I mean,
that
being a
is
dentist,
probably
and I obviously regularly go to my dentist. I
right.
don't recall ever doing an OPG just as a, as a checkup.
Yeah, but I think that should be a protocol. It should be probably um, yeah, it should be a protocol. Definitely a protocol.
Yeah, it should be actually. Never thought about it. That is very interesting.
Yeah,
Yes,
yeah,
we thought about it. We
yeah.
all get so totally focused on the potentially malignant lesions that we forget that
Right.
there are a good number of other things that can happen.
Correct. And for the no fault of the patient, because odontogenic cysts and tumors are basically a developmental lesion where patient neither has smoked nor he has consumed alcohol. I mean, alcohol or he has chewed
True.
tobacco, but still he has a debilitating cyst in his jaws.
Yes,
So that is
yes, and
something
very
which is,
locally. Yes.
hmm,
If I
yeah,
remember, that
locally.
very long definition of ameloblastoma had locally aggressive somewhere in it.
Yeah,
That
yeah,
definition, which was a
unicystic.
paragraph long, yes.
Yeah. Functionally
Yes,
benign and
yes,
I
that's it.
mean, locally aggressive and all.
Yes. So we have Dr. Roy with us. Good
Yes.
evening, sir. Could you please explain the role of 5FU when compared to Carnoy's solution?
Yeah, so it is basically 5-fluorouracil.
Right. Of 5
It's
fluorouracil.
basically an anti-metabolite. Basically, it's a chemical. I mean, a chemotherapeutic agent So nowadays it has showed a lot of promise in the management of. I mean, kind of there is a lot of study, but unfortunately I don't have much of experience because just before my last case, I was also. I mean, somebody. I also came to know that there is role of this 5-fluorouracil in the management. I mean, it is can be substituted to Carnoy solution. But again, this is something which has come up very recently, and uh, we need to have a very long term follow up of these cases. There are some articles which explains the role of 5-fluorouracil in management of aggressive benign odontogenic neoplasm. But the point is, like, we need to have a long-term follow-up of these cases. So probably, yeah, this is something which is new into the field actually.
Something to work on.
Yes, sometimes there is a lot of further studies with long-term follow-ups are required to establish the basis of this 5-fluorouracil in the management of, or to call it as a substitute to Carnoy solution.
Interesting. Right. So we are just actually 3 minutes left to the hour.
Yeah.
And
Okay.
yes, it was a good lecture. Thank you. And good
Yeah. Thank you very
discussion.
much.
So let me
Yeah.
bring in your, yes, your little certificate, a
Yeah. Thank you very
gesture
much.
from us
Thank you.
to say thank you for your efforts
Yeah.
and for being
Yeah.
there.
Yeah. Yeah. Thank you very much. Thank you very much.
Thank
It
you.
was wonderful to be in this podium and to be associated with Oral Pathology 360.
Thank you so much. Thank you.
Yeah.
And
Yeah.
we are new, relatively new with our oral surgery lectures because we really
Yeah.
integrated oral surgery only last year. But
Yeah.
we are building on it, and we will be hopefully building more and more of our audience to really reach the point where now we are truly, now when we say oral pathology 360, we are not really thinking just pathology, we are thinking oral
I
diseases
understand.
in that sense
Right.
of pathology.
Right.
So hopefully we will be expanding and we will be reaching more and more people.
Yeah.
Yes, and thank you, Dr. Abdurrahman, for being with us. And thank you, Dr. Eliza, Dr. Divya, Dr. Alexander, Dr. Bhuvan. Yes, and of course, Dr. Suvek Roy and Dr. Rahul. Yes, and of course,
Yes.
thank you, Dr. Pramod.
Yeah. Thank you
Thank
very
you,
much.
everybody.
Yeah. Yeah. Yeah.
See you all in 2 weeks, and also hopefully in our other classes that are going on. Have a wonderful time. Bye.
Yeah.